Hi, everyone. Welcome back to our podcast. Today's episode is all about pain, specifically, pain as a disease and pain as a symptom. We'll be working through Chapter 12 in our Neuroscience Fundamentals for Rehabilitation book by Lundy-Ekman. And by the end of today, you'll be able to explain why chronic pain is not just acute pain that lasted too long, and why many chronic pain conditions require a different treatment mindset. So let's start off with the fact that pain is not just tissue damage. We want to have a core mindset shift here. Pain is more than a simple sensation arising from tissue damage. Pain emerges from the nervous system that contains both inhibitory and excitatory circuits. Circuits that can diminish pain, amplify pain, or even generate signals that are interpreted as pain. We'll also use this definition of neuropathic pain. This is pain that arises as a direct consequence of a lesion or disease affecting the somatosensory system. You have your acute pain and chronic pain. Acute pain is usually short-lived, resolves when the noxious stimulus is removed or tissue heals, and it's detected by nociceptors. On the other hand, chronic pain lasts or recurs for longer than 3 months. And important, something called acute or chronic doesn't automatically tell you which neuropathological processes are happening underneath. And this is huge clinically. If you assume chronic, it means ongoing tissue damage. You can end up chasing a source that probably isn't there. So now let's talk about chronic primary versus chronic secondary pain. Here's the simple distinction. Primary conditions arise independently of other conditions, and secondary conditions arise as a consequence of other conditions. When we look at chronic pain as a disease, the chronic primary pain exists without tissue damage and has no beneficial biologic function. The pain syndrome itself is a disease. Neural dysfunction creates pain even when there's no tissue damage to explain it. A helpful metaphor when thinking about chronic primary pain is a malfunctioning burglar alarm. There's no burglar there, but the alarm is blasting anyways because of a gain of function in the central nociceptive system. This type of pain involves abnormal nociceptive processes through the CNS, and chronic primary pain includes fibromyalgia, complex regional pain syndrome, chronic nonspecific low back pain, and migraines. Even when no discernible tissue damage is there, the person does feel the pain. On the other hand, we have chronic secondary pain. This starts as a symptom of another medical condition. Causes can include continued stimulation of nociceptors from tissue injury, like nociceptive chronic pain. This can be indicative in cancer pain, maintained signaling even after tissue healing, and damage to the somatosensory system, so neuropathic chronic pain, where pain arises from system damage rather than nociceptor stimulation, for example, sciatica. We have central sensitization, which is described as a main mechanism underlying chronic pain and as a gain of function in the central nociceptive system. What drives that gain of function? We have increased excitatory transmitter receptor activities in the nociceptive neurons, long-term functional changes leading to hyperexcitability, spontaneous activity, and structural changes, and we have rewiring of CNS connections. We also have more facilitation of pronociceptive signals and less influence of antinociceptive signals. Two key brain level points here. Healthy people and people with chronic pain syndrome show different brain activation patterns in response to painful stimuli. And as pain transitions from acute to chronic pain, processing shifts from primarily sensory regions towards emotional motivation structures. Additional mechanisms that can strengthen central sensitization include reduced activity in descending inhibitory tracts, which includes the raphispinal and the cerebrospinal tract, an increase in activity in descending facilitatory tracts, and in some case, pain can be generated without nociceptive input. So here's some signs and symptoms of central sensitization. First, a term that you'll hear a lot are diesthesias. These are unpleasant abnormal sensations, either evoked or spontaneous. Now we have the big symptoms here. Hyperalgesia is an increased pain response to nociceptive stimulus due to sensitized neuron responses in the nociceptive system. Allodynia is perceiving an innocuous stimulus as painful. A classic example of this would be putting on a shirt after a sunburn. Chronic primary pain syndromes can also involve hypersensitivity to scents, lights, and sound. You have spontaneous pain, which is pain that's temporarily distinct from external stimuli. Likely causes of this include ectopic firing of nociceptor axons or neuroplastic changes in the central nociceptive system. People often describe it as burning, shooting, or electrical sensations. And then we have temporal summation. So temporal summation is perceiving increasing pain in response to repeated stimuli or continued presence of stimulus. Winding up is amplified output of the second order neurons in the dorsal horn or spinal trigeminal nucleus. We also have secondary hyperalgesia, which is the spread of pain into adjacent non-injured tissues, like a paper cut where surrounding areas become painful or a little hypersensitive. And one more contrast term, we have paresthesias, which are abnormal sensations that are painless. That's distinct from diesthesias. So let's talk about chronic primary pain syndromes. Chronic primary pain syndromes are primarily due to central sensitization, and they're among the most challenging, but also can be some of the most rewarding conditions for rehab when quality of life improves. 4 key examples of these chronic primary pain syndromes are fibromyalgia, migraine, complex regional pain syndrome, and chronic nonspecific low back pain. Let's chat about fibromyalgia first. Fibromyalgia literally breaks down as fibro or fibrous tissues, myo, muscles, and algos, pain. It includes muscle, soft tissue tenderness, stiffness, and aching pain. It's common, about 2% of the population, with widespread pain not following dermatomes or peripheral nerve distributions, and it's linked to central sensitization. It can also be associated with sleep issues, GI disturbances, concentration and memory issues, and fatigue. Half of susceptibility is genetic or epigenetic. It's not just subjective pain or a psychological disorder. Compared to controls, people with fibromyalgia have less gray matter density and activity in the CNS regions that inhibit pain, plus enhanced pain facilitation. Clinically, stigma is a big barrier. More than half report physicians not taking them seriously. Diagnosis often requires multiple physicians and time, and depression does not cause fibromyalgia. Relevancy for rehab for OT and PT, some treatments that have been shown to help could be heated pool therapy, physical reconditioning, biofeedback therapy, relaxation training, stress management, activity moderation, and reduction of pain behaviors. The next one we're going to talk about is migraines. So migraines are described as a brain-initiated central sensitization syndrome involving dysfunction in the hypothalamus and the trigeminothalamo-cortical pathway. The World Health Organization, classifies migraines as highly disabling. Migraines occur as recurrent episodes. Criteria include 4 to 72 hours of duration if untreated or unsuccessfully treated, plus headache characteristics like unilateral location, pulsating quality, moderate to severe intensity, and worse with routine activity, and associated symptoms like nausea, vomiting, photophobia, phonophobia. Prevalence, it's about 18% of females and 6% of males have one or more migraine per year. Triggers for migraines commonly include stress, barometric pressure changes, lack of sleep, low blood sugar, and, when relevant, a decline in estrogen. Migraines are described as having overlapping phases. You have your prodrome, your aura, headache, and postdrome. Prodrome is an abnormal hypothalamus activity with symptoms like fatigue, mood changes, hunger, sensory sensitivity, muscle tenderness for hours to days. Your aura is a transient neurological symptoms, including your sensory, motor, and cognitive areas. and it's often reporting, people often report visual symptoms like a loss of a visual field or sparkling dots in the air. It happens in about a third of people with migraine and is associated with cortical spreading depression, a wave of depolarization and ion shifts spreading across the cortex. The next phase is a headache phase. So your trigeminal neurons provide sensory input from within the skull and face. The brain itself has no sensory innervation. These trigeminal nociceptors synapses in the trigeminocervical complex, or the TCC. The TCC also receives input from greater occipital nerve, dural branches of the vagus nerve, and C1 to C3, meaning head and upper cervical nociception converges there. A major TCC output is to the thalamus, then the cortex, contributing to allodynia, photo or phonophobia, impaired thinking, and nausea vomiting via visceral nuclei. Kinesiophobia is highlighted. Movement can stretch the dura and dural vessels, ordinarily innocuous, but during the migraine headache phase, this mechanical input can activate sensitized trigeminal thalamocortical system, so people avoid movement to avoid worsening symptoms. There are two proposed headache phase mechanisms. One, the hypothalamus signals the TCC. The trigeminal neurons release CGPRP and substance P, activate nociceptors in face, dura, and vessels, and signals return to the TCC, then to the thalamus and the cortex. The other one is the hypothalamus lowers transmission thresholds between thalamus and cortex, increasing pain perception. Our last phase is the post-strom phase. Our headache is resolving. The person with a migraine's headache is resolving gradually. Symptoms may include concentration problems, weakness, fatigue, nausea, and mood changes. Decreased brain blood flow is noted. For therapy, you can do different things to help out with migraines. Spinal manipulation has shown small effects. Aerobic exercises reduce migraine days and improves quality of life. Physical therapy can include postural, cervical range of motion or exercises. Occupational therapy can include attempts to minimize triggers, maybe activity modification, self-management, and body mechanics. Our next syndrome is going to be complex regional pain syndrome, or CRPS. CRPS is a syndrome of pain, vascular changes, and atrophy, often distal, and sometimes stocking glove distribution. It commonly follows surgery, fracture, crush injury, or sprain, though it can occur spontaneously. Hallmarks of CRPS include severe spontaneous pain out of proportion to injury, hyperesthesia, and allodynia. The acute phase is warm with redness, increased skin temperature, and edema. The chronic phase is cold with cold, atrophic skin and autonomic deficits like hyper or hypohidrosis. Late stage can include muscle atrophy, osteoporosis, and arthritic changes. Therapy is essential to avoid kinesiophobia and includes exercises, education, somatosensory rehab, functional activities, coping skills, relaxation, connective tissue massage, active range of motion, and joint mobilization. Now we're going to talk about chronic nonspecific low back pain. So about 90% of primary care low back pain can't be attributed to a single structure. 1 month prevalence is about 25%, and roughly 70% resolves within 6 to 12 weeks, but around 30% persists beyond that and becomes chronic nonspecific low back pain. One key concept is a testing paradigm that reduces pain in healthy people can increase pain in people with chronic nonspecific low back pain, implying a shift from normally anti-nociceptive process to a pro-nociceptive one. Treatments that are helpful for acute low back pain are ineffective or only minimally effective for those with chronic nonspecific low back pain. Repeatedly targeted a supposed nociceptive source that may not exist can worsen distress and disability. Psychosocial interventions like relaxation and cognitive behavioral therapy can help, and cognitive functional therapy is described as more effective than manual therapy or exercise alone. So now we can talk about chronic secondary pain syndromes. These are peripheral and central sensitization together. So chronic secondary pain is driven by an underlying disease or a specific injury. Both peripheral and central sensitization occur. Peripheral sensitization, or increased activity of peripheral nociceptors, can drive cellular changes that lead to central sensitization and may maintain it. If severe pain persists beyond 24 hours, neuroplastic changes can occur that are associated with intractable chronic pain. These changes resemble long-term potentiation, meaning they can be stable and long-lasting and are hard to reverse. Clinically, multiple sites may contribute at once. For example, after an injury, pain at 4 months might involve a combination of nerve damage, ongoing inflammation, and central sensitization, each amplifying the experience. Let's talk about neuropathic pain and the contributors and peripheral versus central. So neuropathic pain is from lesion or disease affecting the somatosensory system, and it's categorized as a type of chronic secondary pain. The DN4 questionnaire is mentioned as a way to help determine whether pain is neuropathic. There are 3 mechanisms that produce neuropathic pain. 1, central sensitization. 2, ectopic foci. These are action potentials generated without peripheral stimulation, often from demyelinated axons, regions, or dorsal root ganglion somas. The channels get inserted into demyelinated areas. And then 3, ephaptic transmission, or a crosstalk between demyelinated regions due to loss of insulation. Neuropathic pain can arise from abnormal activity in the periphery, dorsal horn, brainstem, or cerebrum. Now, peripherally, you may have a peripheral nerve injury or disease, and it could often lead to sensory abnormalities. We have small fiber neuropathy. This is damage to small diameter afferents like C fibers and alpha delta or A delta fibers, while large, medium myelinated fibers remain intact. Symptoms can include numbness, paresthesia, diesthesia, and pain, often electric shocks, cold sensations, itching, burning, and stocking glove distribution on the hand. Pain can be spontaneous and paired with hyperalgesia and allodynia, sometimes so severe that sheets are unbearable and foot tents are needed. Autonomic involvement can alter sweating, saliva, tears, and affect GI and micturition. Causes can include diabetes, immune disorders, vitamin deficiencies, chronic alcoholism, genetic disorders, post-therpic neuralgia, like we see in shingles, and Guillain-Barré syndrome. Central neuropathic pain comes directly from CNS neuron damage felt in the body area corresponding to the lesion. After a spinal cord injury, the thalamus may generate pain. Neurons in the VPL nucleus can become spontaneously active without spinal input. Post-stroke pain can follow somatosensory pathway lesions. A subtype, deafferentiation pain, where loss of afferent input leads CNS neurons to become abnormally active. Dorsal root avulsion can cause a burning pain in the area of sensory loss, which is most commonly from trauma. We have phantom limb sensations, which means the person experiences sensation from the missing limb after an amputation. When painful, it's called phantom pain. It must be differentiated from residual limb pain. Both PNS and CNS contribute to this one. One PNS-focused treatment mentioned is surgical rerouting of amputated axons to nearby muscles, which is helpful for preventing phantom pain in new amputees and reducing severity in established cases. CNS contributions include overactive nociceptive pathways and maladaptive reorganization in the spinal cord, thalamus, and cortex. Therapy highlights include mental practice and mirror therapy. So now we can discuss medications that are used for chronic pain and what you need to remember about them. The best results suggest that about 4 people need to be treated for 1 person to clinically show any meaningful improvement. Medication options that are listed include tricyclic antidepressants, When it's given for chronic pain, it's often a lower dose than depression treatment. SNRIs, or serotonin norepinephrine reuptake inhibitors. These decrease the reuptake of serotonin and norepinephrine. And anticonvulsants like gabapentin and pregabalin. Opioids are noted as not superior to placebos for chronic pain and may cause fatal respiratory depression or addiction. Cannabinoids are discussed through an endocannabinoid mechanism. They are produced in the body, released post-synaptically, travel retrogradely to presynaptic terminals, bind receptors that inhibit presynaptic release of excitatory neurotransmitters along ascending nociceptive pathways. Marijuana-derived cannabinoids may have an analgesic benefit, but large randomized trials are noted as lacking. We can view this all through a biopsychosocial model of chronic pain. So expectations, cognition, and emotion affect our pain experience. Anxiety, depression, and catastrophizing predict reactions to pain and coping ability. Catastrophizing predicts disability independent of other psychopathology. Expected pain influences processing in medial and lateral pain systems. Negative emotions and stress can increase pain by increasing attention to pain, intensifying muscle tension, decreasing role performance and social participation, and reducing neural inhibition in nociceptive pathways. Social stressors like low income and poor job environment also correlate strongly with chronic pain measures. And therapists are told to address the 3 Ds of chronic pain, which are disuse, distress, and disability. Psychological interventions that are listed for chronic pain include relaxation, biofeedback, imagery, cognitive behavioral therapy, including challenging dysfunctional beliefs and modifying behaviors, and education about pain pathology. Placebo-associated improvement and using it ethically. Let's talk about the placebo-associated improvement. And it refers to genuine psychologic or physiologic effects attributable to receiving a treatment, not the inherent power of the treatment itself. It's reframed as something you can mobilize ethically via positive but honest communication, encouragement and education, building trust, compassion, empathy, understanding the person as an individual, and creating meaningful rituals that build expectancy. Explain Pain is an education on the neurobiological basis of pain, shifting the view from pain is equal to tissue damage to pain as perception. Pain is real, but modifiable. Results are mixed depending on the population and study design, but it may work best in combination with other strategies. People with chronic pain often want providers to acknowledge them as individuals and recognize pain as biological based, while providers may focus more on the diagnosis, treatment, rather than providing biological explanations. A key factor for positive interaction is explaining recommendations in a way consistent with the patient's existing beliefs about their chronic pain. So, to wrap it all up, all chronic pain conditions involve central sensitization. Therefore, treatments for acute pain are often ineffective in chronic pain. And rehab providers should use the biopsychosocial model and set realistic goals and expectations. Treatment is unlikely to completely eliminate chronic pain. So that's chapter 12. If you take nothing else from this episode, take this. When pain becomes chronic, the nervous system itself may be the generator or the amplifier, and your treatment plan has to match that reality. Hope you all have a good day.